Hello, Mr. Senator. Our names are Adrian Rhodes, Ali Benestro, Tom Leffenchuk, Rochelle Turlink, and will be giving an in-depth briefing on HR 2530/S1113, also known as the Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act. This briefing provides an objective, data-driven synthesis of how federally mandated nurse-to-patient ratios impact clinical outcomes, hospital accommodations, as well as workforce sustainability. We will look at the rigorous clinical data, providing how these mandates not only protect patient lives, but we will also explore how equally address the very real operational and financial concerns raised by hospital administration and rural healthcare networks. By the end of this brief, Mr. Senator, your office will be comprehensive, data-driven insights necessary to support the legislative action on this issue. Our goal with the structure of this next slide is to present to you both of our specific policy ask and a roadmap for today's briefing to give you a clear idea of where we're heading today. On the left is our policy ask, where we'll be advocating for three specific pillars of support. We ask for your support, Mr. Senator, with a co-sponsor for the Advancement of Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act to help establish legally enforceable and national staffing floors. Studies have shown that strict nurse-to-patient ratios have shown a remarkable increase in patient care metrics, patient satisfaction score, as well as decrease in nurse burnout and turnover. Our second pillar would be workforce protections, as we would like to pair the standards with an increased federal pipeline of educational grants. Ratios only work if we are actively training and retraining the clinical workforce within the hospital setting. Our last pillar is safety net safeguards, where we will urge the inclusion of targeted transition funding and compliance timelines for vulnerable, rural, and critical access facilities that face unique geographical hiring hurdles. Typically, the most at-risk populations for lack of medical care are those who are in underprivileged and rural areas. We want to make sure those areas are included with the framework of our policy. On the right, you can see our briefing roadmap. To ensure you are fully prepared for votes and questions from our colleagues, we will walk you through the roadmap. First, the legislative landscape, we will be comparing these federal bills to existing state-level frameworks with states such as California and Oregon. These states have mandated nurse-to-patient ratios currently enacted, which will provide insight into support for this bill. Second, the clinical evidence regarding patient mortality, hospital-acquired infections, and nurse burnout. Third, we will present a balanced analysis weighing the massive long-term workforce ROI against immediate hospital operational costs. And finally, we will wrap up by addressing the toughest strategic questions we anticipate your office might receive from the hospital lobbies and healthcare unions alike.
This policy addresses a lack of federal patient safety standards, chronic nursing burnout, and a misunderstood nursing shortage, and a decline in patient quality of care. First, let's look at the lack of patient safety standards. The federal government does not set a limit on the number of patients assigned to a single registered nurse. Medicare's conditions or participation only requires hospitals to provide adequate or sufficient number of licensed nurses. The vague regulation has enabled hospitals to understaff nursing units to reduce costs. Extensive clinical research demonstrates the risk in adult medical surgical units. Its additional patient assigned to a nurse increases the risk of a patient's death within 30 days by 7 to 8%. Second, these extreme workloads driven by understaffing to reduce costs have led to widespread of chronic nursing burnout. Burnout is more than workplace fatigue. It is severe psychological response marked by emotional exhaustion, by depersonalization. When nurses must choose which critical care tasks to delay due to extensive demands, these decisions cause significant moral injury. Over time, this moral injury contributes to burnout and drives nurses to leave the profession at high rates. The moral injury has led to hospital lobbies described as nursing shortages through the data shown. The real issue is poor bedside nurse retention. There is no shortage of qualified registered nurses. Instead, there is a shortage in nurses willing to risk their license and patient safety by working in unsafe conditions. As working conditions decline, nurses leave bedside roles, forcing hospitals to depend on costly temporarily travel contracts. Finally, all these contracts result in significant measurable declines and quality of patient care. When nurses are exhausted and overextended, clinical vigilance decreases, leading to more hospital-acquired infections, medical errors, missed care, and lower patient satisfaction scores. By falling to regular staffing minimums, the federal government has left patients and clinicians in an unsafe, unsustainable situation. The Nurse Staffing Standards for the Hospital Patient Safety and Quality of Care Act aims to address this crisis, which we'll discuss in the next.
On the next slide, we will dive into the overview of the legislation. The Nursing Staffing Standards for Hospital Patient Safety and Quality Care Act was introduced by the U.S. Representative Jan Swarsky and U.S. Senators Alex Padilla and Jeff Merkley. During the 118th Congress in 2025, the goal for this legislation is to improve hospital patient care and nurse retention by setting mandatory minimum registered nurse to patient staffing ratios. There are no current federal mandates regulating the number of patients a registered nurse can care for at one time in the U.S. hospitals. This act will provide a legally enforceable nurse to patient ratio mandate that, depending upon which unit type and patient acuity, will determine the ratio. For example, it mandates a strict 1-to-1 patient in ratio in emergency trauma units, a 1-to-2 ratio in intensive care units, and a 1-to-4 ratio in standard medical surgical units. We want to emphasize these numbers have been established as the minimum baseline standards, not a ceiling which ensures a national safety floor. One of the most common concerns raised by hospital administrators and legislators is that rigid ratios do not account for daily operational realities. The bill directly addresses these concerns by mandating that hospitals collaborate annually with frontline direct care nurses to develop data-driven, acuity-based staffing plans. This means if patients on a unit are acceptably sick on a given day, the hospital must adjust staffing levels above the legal minimums to match the clinical need. For these new standards, they are only as good as their enforcement. The whistleblower protections provision provides critical federal protections, insulating direct care nurses from workplace retaliation, demotion, or termination if they refuse an assignment that violates the legal ratios, or if they report a facility's non-compliance to regulatory authorities. Moving into the first phase of our roadmap, Mr. Senator, let's look at the legislative landscape for HR 2530 and S 1113. The legal scope of this legislation is comprehensive, applying to all acute care hospitals nationwide that participate in the Medicare programs. It replaces our current vaguely worded federal requirement of sufficient staffing with precise ratios that are dictated to hospitals. Specifically, the bill establishes legally enforceable shift-by-shift ratios for particular units such as 1-to-1 ratio in emergency trauma, 1-to-2 in ICUs, and 1-to-4 in medical surgical floors, nursing staffing standards for Hospital Patient Safety and Quality Care Act. To ensure these rigid numbers don't restrict administration realities, the bill utilizes a dual mechanism. It mandates that hospitals collaborate annually with direct care nurses to create acuity-based plans, meaning these ratios serve as a safety floor, never a ceiling. This legislation is deeply informed and based on the structural frameworks already tested and in place at the state level, most notably in California and Oregon. California's decades-long history with enforced nurse-patient ratios has shown structurally stabilize the nursing workforce without forcing hospital closures. These rigid, strict ratios have shown to help with protecting investments in nursing staff and associated quality, safety, and outcomes of care during vulnerable times of economic stress across the healthcare industry. Oregon passed a model that mirrors that current federal bill by introducing the modern framework of nurse-patient ratios, combining numeric safety floors with strict legal accountability for hospital staff and community. The data from these states demonstrates a powerful truth. Clear legislative boundaries driven by long-term workforce stabilization without causing a decrease in overall patient safety or care.
Next, let's dive into the core clinical evidence that supports this policy. When we talk about safe staffing ratios, we are talking about setting an absolute baseline of safety, such as 1 nurse to 2 patients in an intensive care unit or 1 nurse to 4 patients on a standard medical surgical floor that we mentioned in previous slides. The numbers are not arbitrary, as they are backed by decades of rigorous empirical health services research on the topic. Decades of peer-reviewed research, such as a landmark study led by Dr. Linda Aiken, shows that in states without a minimum nurse-patient ratio floor, there's a direct mathematical link between these numerical ratios and an increase in patient mortality. In a medical surgical unit, the data shows that a 1-to-4 ratio optimizes patient care outcomes. However, when a hospital is chronically understaffed and that ratio increases to 1-to-5, 1-to-6, or higher, the risk of a patient dying within 30 days increases by 7 to 8% for every single additional patient added to the nurse's workload. The power of the nurse-patient ratio allows nurses to have the proper clinical vigilance needed to help prevent any increase in patient mortality. When the overall ratio is stretched too thin, nurses lose the physical time required to notice these subtle changes, leading to what we call failure to rescue. This inability of nurses to spot and intercept early signs of patient deterioration lead to costly hospital-acquired injuries that are easily preventable with proper nurse-to-patient ratios. These reasons for safe nurse-patient ratios are exactly why safe staffing ratios are the primary mechanism for burnout prevention. As a follow-up to our earlier background slides, burnout is a severe psychological response to moral injury. When a nurse is forced into an unsafe ratio, they physically cannot complete every vital care task, forcing them to choose which care they delay. This human toll can cause a nurse to physically, emotionally, and spiritually deteriorate, causing delays in care and moral injury. By legally establishing a safe numerical ratio floor, we protect the nurse's bandwidth for care, eradicate the moral injury, and stop the bedside exodus while protecting the patient's life and nurse's license simultaneously. Now, Mr. Senator, let's pivot to the critical economic dimension of this legislation. Hospital executive lobbies frequently argue that federally mandated ratios are an unsustainable expense, but when we take a deeper look at the data, it reveals a profound return on investment. When we look at what understaffing actually costs an institution, replacing just one single bedside registered nurse who leaves due to burnout costs the hospital upwards of $50,000 in recruitment, vetting, and onboarding of a new hire. With the frequency in which nurses are leaving the profession due to burnout, this number can climb into the millions of dollars to hospitals on a yearly basis. Due to this lack of retention of nurses, hospitals are forced to plug the staffing holes left vacated by these traditional staff nurses using temporary travel nursing contracts. These contract nurses command a massive premium that drains hospital operating budgets far more than investing in a stable, permanent workforce would. When these staffing concerns are addressed and proper nurse-patient ratios are established, patients are able to receive timely interventions to their diagnosis, recover faster, and experience a shorter hospital length of stay. This helps reduce the overall length of stay in the hospital, helps decrease the readmission rates, and increases the overall patient care and safety standards for the hospital. Focusing a hospital strategy for economics on one that is aligned with the updated patient care protocols of the Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act, this will help improve the overall health of the economic landscape for the hospital setting. To ensure your office is fully prepared for any questions or upcoming debates, we wanted to objectively evaluate the counterarguments that could be raised by hospital administrators and rural health executives, and then go over the pros and cons for this bill. Opponents of the bill may argue that the bill would put a financial and institutional strain when looking to implement the mentioned changes from previous slides. Upfront labor costs of hiring new staff to accommodate newly federally mandated patient ratios can hurt most critically rural critical access hospitals who already face severe geographic hiring hurdles, as many rural hospitals simply don't have the local labor pool to comply with updates overnight. The institutional concerns of patient surges and the inability to provide care for those increased patient numbers due to the rigid top-down updated numerical mandates of nurse-patient ratios of the bill may limit an administrator's capacity to pivot to increase ratios during localized volume surges. Concerns such as these are valid in nature, but as you will see in the next slide, the benefits of the policy will clearly outweigh the challenges.
Breaking down the overall pros and cons for the federal policy shows how clearly the benefits outweigh the risk. The benefits that we see in research show that nurses with fewer patients can focus more on the patients that they have and more free time to frequently round on them. Infection is less likely to be spread when nurses have safe nurse-to-patient ratios, and these improvements help lead to a decrease in the patient mortality rate and improve the overall clinical quality of care nurses can provide. With fewer patients and a more manageable assignment, nurses are less likely to burn out and feel more supported. These improvements can help lead to an overall stabilization of the workforce, helping to stabilize the healthcare industry as a whole.
As mentioned on the previous slide, major upfront costs will have to be made to help get the policy in place. The vulnerability of a rural area, hospitals, and the lack of potential candidates can lead to a major hiring hurdles for this area in the institutions. The final challenge would be the inflexibility of staff assignments in cases of emergencies or during times of patient surges.
Advanced practice nurses frequently lead to efforts to address patient safety and quality of care, particularly those affected by staffing. They advocate for staff and patients to maintain high standards and model effective communication that aligns with hospitals' mission and vision.
To ensure your office is fully prepared for the upcoming debates and questions, we must objectively evaluate the counter arguments raised by your opponents. Our primary tactic would be to focus on the evidence-based answers for potential questions, 3 of which we have drafted for you. Questions such as, will rigid federal ratios restrict an administrator's capacity to handle unexpected localized patient surges? And with an active national nursing shortage, where will hospitals source the personnel required to legally comply with these mandates? The use of evidence-based, data-driven answers allow for us to acknowledge these realities and provide the opposition with adequate real-time answers. One question we would ask for you in your office is, if the political climate delays the passage of a federal mandate, what policy steps can this office support to improve bedside safety? We would like to know your thoughts on the matter, as we believe transparency and funding expansion are bipartisan ideals that can be heard and potentially implemented in the case of a delay. In conclusion, the Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act represent a definitive evidence-based turning point for American healthcare. The data clearly shows that this policy protects patient lives, halts the devastating moral injury currently affecting our workforce crisis, and delivers a powerful economic return by curbing costly turnover. This is demonstrated by nurse-patient ratios, which reduce nurses' burnout, patient harm, and nurse turnover. This bill increases care for all patients in the community, especially those in vulnerable and rural networks. With the expansion of educational grants, this bill presents a balanced framework to help with implementation into those communities who need it most. And with your support, Mr. Senator, we can help make hospitals safer and better for our communities. We strongly urge you to move forward as a co-sponsor of HR 2530 and S 1113 bill, Mr. Senator, and help lead the legislative movement to secure a safe, sustainable future for our nation's healthcare system.
Thank you for watching and listening to our presentation. We look forward to your feedback and questions, and please let us know in the discussion portion if there's any clarifications we can make. Thank you.